who are working on AI. If I can just see how many of you? Wonderful. Wonderful. You are all creating some kind of AI solutions, right? So for AI, the elephant in the room is the data, right? If you do not get the right kind of data, you cannot train your AI solutions. The AI solutions will not be perfect. They will not be India specific, right? And who holds that particular data today? SC hospitals. Sir, what can we do as technology specialists where we would, without the access to the health data, the AI cannot become perfect? And I know, and again with your permission I am saying, that a lot of doctors say that because the AI is not perfect, or that the accuracy is not as high for a lot of solutions, which is true, and hence it cannot be used. But they can only be improved using India-specific health data. For example, CDC in US does give out a lot of generalized healthcare data for creating healthcare solutions. How do we make sure that in India, the healthcare providers help us in creating those particular health solutions?
So I'll answer this question after what was left out. It's very important for the audience and for the recording also.
Oh, sure.
So I will talk about this data part, how it can really help you. But I wanted to, we finished that ECG and echo was left out. So because it's very important, because these, whatever is available has to be further improvised by AI to get the best result and more longevity. Nobody wants to die. This is the problem. And like nobody, there are people who say, okay, today is my last day. If I tell you, lots of patients come at the age of 75. Doctor, I have finished my life. I have done everything. My children are happy. I'm like, what if you get a dream in the night that God comes to you and says, tomorrow is the last day, then nothing will happen. I will be sleeping as normal as all. But I feel a lot of hypocrisy in this. Nobody wants to die. Everybody wants to be immortal. Even like
longevity is becoming a big industry, sir.
Longevity
is actually
there are a lot
industry.
of companies which are working. So I will talk a little different also, because this is a general session. So sorry for taking more time, but important. There are a lot of companies which are working on the pill, which can be anti-aging. And there is something which is already available, not completely proven, which I take personally. I'll give it to you also. So coming back to the cardiovascular disease, because this is the number one killer. Earlier it would be cancer, now it is heart disease. So when you have a number one killer, so you have to do the best in that part so that the AI can prevent heart attacks, or it can prevent, if it at all happens, it can treat you so well that nobody should die. So this is our aim. In Apollo Hospital, I do a lot of complex angioplasties. I will come in the middle of the night of a 21-year-old gentleman who has a heart attack, or 24-year-old. I will take out the clot in the night and the patient is still living. So I have a lot of examples which are available on my YouTube. If you see Dr. Vivek Gupta on YouTube, you'll see a lot of such education material, especially for young doctors. I give message on every YouTube so that young cardiologists who are working all over India now, a lot of cath labs are working in small cities like Hardoi, like Agra, Mathura, small places, and they are not that skilled cardiologists. So to give them message, I make a YouTube, and when I go to France, I meet French doctors, young. Okay, I watch your YouTube and I'm very happy to learn a message coming from a senior professor from Hyderabad. She comes to me, your message are so important that it really helps people to do what is the best. Because if the doctors take full interest, you can save 2 extra lives, especially in heart. If a doctor does not take full interest in a government hospital, you are so busy doctors, that is why the mortality in a hospital like Apollo versus AIMS is much lesser. Even AIMS, I tell you, because they are having so many patients, they cannot concentrate on one patient. So coming back to the AI and heart disease, I told you about ECG, I told you about how angioplasty was developed, I told you about how stent came up, I told you about medicated stent. Now the time to tell you what we are doing as a high-skilled angioplasty, where complex angioplasty is replacing bypass surgery. There are various tools now to find out the blockage percentage. There's always I want to talk this topic. A lot of people say your unnecessary stenting is being done. All over media are saying you put a stent unnecessarily. This hospital, this doctor has made a mistake. I want to clarify from this forum of Mr. that 99% or 95% of doctors or the hospitals will not put unnecessary stent. I can tell you, one or two patients, people will do it out of not greed, out of maybe pressure, but out of their illiteracy or not so much experience. A percentage stenosis is very important, and AI can help us. We will not put a stent, or it is not advisable to put a stent unless the blockage is more than 70%, and 70% diameter stenosis. In the artery, which is having a diameter of 2.5, you are magnifying it, and with the help of very special diameter stenosis algorithm, you are finding out the percentage stenosis. I would say I've really experienced. I've done more than 8,000 procedures or 10,000. I worked in France with best of the doctors. I trained myself I went to zero. Immediately after DM, I went to France. At that time, angioplasty was not known in India, 96, 97, 98. Very uncommon. So I learned angioplasty there from zero, citing publications, more than 50 publications during 2 years of my stay in the best of the hospital in France. With Alan Crivier, who is the father of TAVI, which is, I'll tell you what it is. So I'll take extra time. It's very important because people should learn. So percentage stenosis can be missed out. If it is 50%, people will be not putting a stent. If it is 70%, they will put a stent. So there's a gray area. Now the clinician has to decide whether that percentage blockage is causing angina, or it is vulnerable, it can lead to heart attack or not. Any patient who has 90% stenosis, there is no doubt you have to put a stent. 100% you have to open with a wire. 99% there is no doubt. The only thing is where it is 50% or less than 50%. Here, sometime the ball, what's your eyeball? This is eyeball, you see, assessment. And of course, the QC, which is quantitative computerized analysis assessment by the cath lab, can err. And here, there may be few patients where you may have put a stent which may not have been required. May. It's a question of may. So I would say unnecessary stenting is just a myth, it is not a reality. Coming on to what best we can do and what we are doing it. When we find a 50% blockage or 70% blockage, we will put a wire which is FFR, again it is now AI, which is a wire, not on the percentage. Now we are not believing on percentage stenosis. We are finding a pressure difference between the proximal and distal part of the blockage. If it is less than 0.8, which is FFR, fractional flow reserve, will put a stent. If it is more than 0.8, will not put a stent. And the high quality cath labs like Apollo will have this such FFR, and only few people in the all interventional cardiologists will know how to do it, and few technicians can assist it. So FFR is one. Another is imaging. What is imaging? Like X-ray. You're doing X-ray of the chest. What we do, we put a catheter inside the coronary artery, again from the groin. Sorry for using it. Groin coming onto the aorta, coming like this, going to the coronary artery, as small as 3 millimeter, putting a very miniature camera, which will go inside the artery blockage, and you will take image, and that will be seen on the computer. That image is known as OCT, optimal coherence tomography, and that will tell you exact percentage stenosis. Similarly, intravascular ultrasound. Ultrasonic picture will go. So we are doing really in a patient who is fully active, and my patient starts singing. I tell him to sing a Kishore Kumar song while I am performing the procedure. And there are a lot of videos like this. I was just checking. Yeah, I write Dr. Vivek Gupta, angioplasty, and singing. And a lot of videos came that patient is singing himself. I forgot myself. He's singing a song, and I am enjoying, and I am performing the angioplasty on his patient or angiography on that patient. So, amazing. Miniature camera will go and again tell you the plaque. Now there are two types of plaque. But the plaque means how AI can help. Plaque is cholesterol material. Plaque means PLAQUE. It's a cholesterol material. There are few plaques which will rupture. Rupture means it will get eroded inside. I'm talking of 3 millimeter artery, plaque of 30%. It gets eroded, invite platelet and clot formation. This is the pathophysiology of heart attack. The pathophysiology of angina, which is chest pain going on walking, is a cholesterol deposit fixed, no plaque. A plaque is there, but it is fixed. It is not vulnerable. So vulnerable plaque, even 30% can lead to heart attack, while a non-vulnerable plaque will not lead to heart attack. Vulnerable, VULNERABLE. Vulnerable plaque means it's vulnerable to plaque rupture, and it will invite clot formation. Heart attack happens because of clot formation, while angina will happen only with a fixed blockage where you put a stent. So this plaque is very dangerous. You have seen people singing and singing and singing, suddenly collapsing. What is happening is, the plaque which was 30% was not causing any pain to him. 20%, 10% was not causing any pain. Any specific precipitating factor A 10% blockage is not causing any pain because only 70% block, which will cause pain when you walk or you go upward or when you rest or you take a bath, you will have a pain. This is known as angina, chest pain. Heart is crying because it is less supply of the blood because of the blockage. This is angina. You have no angina and suddenly you collapse and die. So this is because that vulnerable plaque which was there, which was undetected by ECG, undetected by echo, undetected by X-ray, and the patient is given clean check by any hospital, your echo is fine, your ECG is fine, you are all right. And next day he comes, he says, okay, I have severe pain. He comes to cath lab like Apollo, we'll take him to cath lab, do angiography, take out the clot and this. The clot will cause heart attack, cholesterol, the clot over the cholesterol will cause heart attack, while cholesterol alone will not cause heart attack. So AI can find out that plaque which is there is going to rupture or not. Because if it is non-rupturable plaque, you don't require any procedure except for few medicines. If it is a vulnerable plaque, you have to be very, very careful, and sometimes even 50% vulnerable plaque, you require a stent so that it stabilizes and does not lead to further clot formation. This is one way. Coming on to another part of AI, how it can help, is bypass surgery. What is bypass surgery? Bypass surgery, you open the chest. Yesterday we have done a non-open chest bypass surgery. Yesterday, I'll tell you that's a mini bypass. That's different thing. Again, robotics can help. You open the chest. It's not the robot which is doing it. It's finally the human being which is doing. But in few years' time, maybe the revolution or evolution will be there. That robot will start. Today, as of now, the robotic cardiac surgery does not the robot. Of course, there are clamps, which is again maneuvered by the cardiac surgeon sitting in another room. It is more precise because these clamps, because when you are stitching with the help of your hand, sometimes if a young surgeon can have a tremors also, and then stitch may not be so. The precision will come if the clamp is there and you see on a video, on the machine outside sitting, and the very precise bypass surgery can be done with the robot. Similarly, for the knee replacement, a robotic knee replacement is much more precise as compared to non-robotic. So robots are helping. That's again through AI. Coming on to the heart failure, very important part, which I want to discuss and tell you. Lot of lives can be saved if AI can find out who is going to have sudden cardiac death. If somebody can be, okay, anybody come to Apollo and we have a machine through which he passes, do the ECG, X-ray, CT scan of the heart, MRI of the heart, and this man will have possibility of sudden cardiac arrest. Because heart can stop. Uski apni marzi hai kab chalna band kar de. People die in the sleep. Why? Because heart stop working. It's a machine. Again, heart is the machine. And you don't know. So if AI can find out, maybe in future, if AI can find out that this particular person is higher risk of sudden cardiac arrest, I'll put a machine known as pacemaker AICD. What is AICD? Automatic implantable cardiac defibrillator. Automatic implantable cardiac defibrillator. What is cardiac defibrillator? You have seen a lot of movies where you do. Patient comes to the emergency, you put a machine and you give a shock. What does a shock do? Shock in a heart which has stopped working, if you shock the heart, it will start working and finally stabilizes. This is a shock which will do. So when we do,
it's like kicking another machine when it stops working, right?
So what is AICD? AICD is a miniaturized shock machine which is given to the patient, those who have a high risk for cardiac arrest. And those high risk of cardiac arrest, as of now, the criteria is if the ejection fraction done by echo. What is echo? Echo is ultrasound of the heart. Echo is ultrasound of the heart. Done by the echo, if you are able, if you have a ejection fraction less than 35%, but there is a big pitfall. I can give you an example of Mr. Raju Srivastav, big comedian, and a personal friend of mine. His ejection fraction was 45%. He had stents, not done by me, but diagnosed by me. He was lived in Bombay. Few were mostly done by there, but my prescription. Sitting with me, the case report is very important. I have no problem in telling the name also. He was sitting, dining with my son, Dr. Vivek Gupta, myself, my whole family members, exactly 48 hours before his death. Singing song, no problem. His wife told me that when she came to know that he's going to visit me, just for a courtesy dinner, he said, Dr. Vivek Gupta ke paas ja rahe ho, to ek baar checkup bhi kara lena. He was taking my medicine. So mistake was taken. So the pitfall was, he was never advised AICD. Why? Because his ejection fraction was 45% And the overall generalized worldwide randomized trial have shown that only if you have a less than 35% ejection fraction, pumping function, then only you put AICD, otherwise don't do, because the chances of having cardiac arrest is much higher in those patients who have an ejection fraction less than 35, not less than 45.
Sure.
He was having 45, but he had early heart attacks. So this is a pitfall. If we had some AI machine which have confirmed that this man is going to have a cardiac arrest, I would have put AICD. Similarly, my professor and Trippier, I give another example, perfectly all right, 45%. The AI tool will help us to prevent sudden cardiac arrest by giving the machine which will be monitoring your heart all the time. When it starts fibrillating or arresting, it will give a shock. Today, one patient visited to me, today only, I told my son that he meet this man, he had a bypass surgery, stenting also done by me, and now he had a machine and he had shock just 5 months back. 3 times his wife was just doing a music sitar and she found her, and then suddenly he came back. So this was the machine which gave a shock and he revived back, his life was there. So AICD, when to do, AI will tell in future. Last part would be, I think I will talk about, because a lot have been talking, it's a late evening and you have to start this thing. But last part was it preventive. Preventive, again, I tell you, nobody wants to die. So prevention is better than cure. But of course, with the data, now I will answer your question. Hospitals have huge data. You must heard of these data can be, of course, all the hospitals should come back without giving the names. Of course, the privacy is very important. You can't give the data of anybody.
Anonymous.
The privacy, they can have a computation. From the beginning, I told you that is a computation of the previous data where AI will help you to find out what is the best treatment for that particular patient. It may be neurosurgery, it can be robotics, knee replacement, or it could be cardiac transplant. Heart transplant is the thing which I have not touched upon, but I think we have another forum with AI with healthcare where I can talk about. Last part which I want to speak about is a small phrase before I end up, because it's already 7:45. Oh, sorry. Last part is, but I am not to be there are a lot of sessions which were going very late. So quantum AI, quantum artificial intelligence is likely to come up, which will be supercomputers, and that will help us groundbreaking field that combines the power of quantum computing with the innovation of artificial intelligence. Result is a powerful tool that can revolutionize the way we can solve problems and discover the new area of healthcare where people will live possibly for more than 150 years, that's precise. What last part, I always tell my patient, he says, डॉक्टर साहब मैं ठीक नहीं हो रहा हूँ, अभी अब कितने दिन दवा खानी पड़ेगी? हमने कहा आपकी उम्र क्या है? 72. हमने कहा 28 साल और खानी है आपको दवा तो खानी पड़ेगी. आपकी 100 साल की उम्र तो मैं सोचता हूँ कि 100 तो दूँ आपको, तो 28 साल और खानी पड़ेगी. तो इससे मैं 100 से माइनस करता हूँ. I tell this many years you have to take the medicine you have to continue taking despite whatever you do, bypass, angioplasty, surgery, whatever medicines are very important because they will prevent further plaque formation, cholesterol deposition, and it will prevent to have it will lead to a good healthy lifestyle. Thank you.
Thank you so much, Professor Gupta. So, closing the session today, Dr. Gupta said that when the heart is crying, he makes people sing Kishore Kumar songs, right? So probably we'll have to call that as.
Really check my YouTube, you'll find Vivek Gupta, Dr. Vivek Gupta, angioplasty, Dr. Gupta, cardiologist singing. You'll find lot of videos.
Absolutely. No, we'll start calling your surgeries as Dil Khol Ke Gana surgeries. Thank you so much. Thank you.
Yes, he has been the witness of that. Yes.
Thank you to everyone for sharing your valuable thoughts, and thank you for everyone for listening very, very patiently and participating in the session. Thank you.
Nobody moved out actually. It was so engaging.